Bismillah ar-Rahman ar-Rahim. My name is Dr. Ali ElGhatit. I'm professor of ophthalmology, Department of Ophthalmology, Alexander University. Today I'm going to discuss with you a topic which is important in the field of ophthalmology, which is the strabismus or squint. In our talk today, or our lecture today, we are going to classify, or are going to divide our topic into four main sections. Number one, what is strabismus? Number two, how do you classify strabismus, and what is the basic examination for a case of strabismus? And finally, how to treat or how to manage simply a case of strabismus. Before we understand strabismus, we have to know that actually the vision we don't see only with one eye, but we see usually with both eyes of us. So in these slides, as you see, when you look to a subject, your right eye will go to see a picture, your left eye will go see another picture, and the brain will fuse these two pictures together in the form of a picture that you see with a 3D dimension, or what we call a depth dimension in your field of vision. So actually you have your field of vision and you have the sides of the field of vision where the area where we call it blind spot. So this is also another simplification. How do you see with the right eye, how do you see with the left eye, and how the visual pathway will guide this picture through your optic nerve, through the chiasma, then through the optic radiation till you're receiving the optic cortex in your brain, and then you are going to see a true picture of your eye, of your vision. In order to see clearly, you have to have a proper balance between the two eyes, and this balance is obtained by your extraocular muscle. Your extraocular muscles are the muscles that guide your eye throughout the whole vision. It has to be synchronized, and they move all together in the all direction of gaze, which is a normal maneuver done simply by your brain with your muscles. So in order to understand the squint, we have to know what are the extraocular muscles of your eye. We have what we call the recti and the oblique muscles. We have superior rectus, inferior rectus, medial rectus, lateral rectus, and superior oblique and inferior oblique muscle. And as you see from this slide, the muscle arise from what we call the aneurysm, which is a tendinous ring present at the fossa, at the orbit. And from this tendinous ring arises the muscle, and as every muscle we know in the body has origin and insertion, the origin arises from the annulus of them, and the insertion is inserted inside the globe itself. So the globe it's a ball attached to its muscle. Muscle moves the globe right, left, up and down, and in torsion and sideways. These are some pictures of the muscle. We have the recti muscles. This is the medial rectus, lateral rectus, superior rectus, inferior rectus, and we have the oblique muscle. As you see from this slide, the oblique muscles arise in or are inserted in a torsional way, so that they are inserted actually not at the side of the eye, but they are inserted at the back of the eye, at the outer or at the inner quadrant at the back of the eye, which gives the muscle a form of torsional movement. It's not like the medial recti, which has only one axis, but they have different axes, and I'm going to show you in the other slides how does this act together. So from this is the annulus of them, where the muscles are originated. And we have here the superior oblique muscle, the inferior oblique, the inferior rectus, superior rectus muscle, the inferior rectus muscle, the medial recti, the lateral recti from the other side, and here comes the superior oblique, and the inferior oblique. We'll show it in another slide. The superior oblique muscle has what we call the trochlea, which guides the muscle or diverts the insertion of the muscle sideways to be inserted underneath the superior rectus. And this is very important for the rotational movement of the eye. The inferior oblique reverse. The inferior oblique actually is not originated from the circle of Zinn, but it arises here from the nasal part of what we call from the lacrimal fossa, from the nasal part of nasal portion of the bony orbit at the lacrimal fossa, and it is inserted here at the outer inner quadrant of the globe. This is the section when you cut and you look at the eye from the back. You see the different insertion of the muscle. Why the muscles are inserted this way? So that each muscle has what we call a primary action and a secondary action. The secondary action, you can see it when the eye present in the abducted position or when the eye is in the abducted position. We have some term, you have to know it, which we call when you look up, you look down, you look right, you look left. When you look to this side, it is called adducted position. When you look to the other side, it is called the abducted position. That means you look outward. Inward toward your nose, this is the adducted position. Then you have elevation, then you have depression. And then you have intorsion, and you have extorsion. Why you have intorsion and extorsion? Because when the head is moved this way, the eye will rotate inward to keep your vision straight. When you move this way, the eye also will move will do intorsion to keep your eye straight with the direction of the movement of the eye. And also when you move sideways, we call what we call the doll head movement. When you move this way, the eye will be shifted this way. When you move this way, the eye is directed this way. This is normal anatomy with normal physiological coordination between the muscles of the eye and the brain and your body, or the whole body movement to keep you balanced while you are moving your head. You feel sensation between the space and your body. It is very important to know the nerve supply of this muscle. The lateral rectus, all the muscles are what we call the cranial nerve. The cranial nerve, or the third or the oculomotor nerve, which is the third cranial nerve, supply all the muscles except two muscles, the lateral rectus and the superior oblique. The lateral rectus is supplied by the abduction, which is the sixth nerve, and the superior oblique, which is supplied by the trochlea, which is the fourth nerve. So we have the third nerve, the fourth nerve, and the sixth nerve. So this gives you an idea, if there is any paralysis of these muscles, it gives you an idea about where the lesion is, where the lesion is actually. So we have what we call main eye movement. Main eye movement, which is, as I told you before, it is abduction, adduction, as you see from this picture. Elevation and depression and intorsion and extorsion. So in each muscle, when they work coordinate together, they move your eye in all direction of the gaze. When you look inward, it is function of the medial rectus only. It moves the eyes inward towards the nose. And by the way, I forgot to tell you, some of these slides are courtesy from Dr. Amr Kamshushi, and I'd like to thank him for this. When you move outward, it is the lateral rectus who are doing this function, what we call abduction. So in abduction, you have only one muscle. Then we have elevation and depression. The elevator of the muscles are two muscles. We have two muscles attached upward and two muscles attached at the lower part of the globe. Side the globe, we have two only muscles, lateral rectus, medial rectus. As long as we have two muscles, that means these two muscles are going to act together when you look up, when you look down. And by the way, when one muscle is stimulated, the other muscle has to be relaxed in order to keep the eye moving in all directions of the gaze. Here comes a little problem in your understanding of the function of the muscle. You sometimes become confused between the superior rectus and the superior oblique, and the inferior rectus and inferior oblique, and how the inferior oblique will lead to elevation and superior oblique will lead to depression, in reverse to superior rectus and inferior rectus. Why is this? For this diagram will illustrate you this. When you look to the adduction, we have only two muscles, medial rectus, lateral rectus. But when you look to the elevation is done by the muscle attached upwards, which are superior oblique. But at the same time, the superior oblique, since it is attached sideways, that means the axis of its action is not parallel to the axis of its insertion. The sort of physics, when you have three axes, you have what we call a vector analysis. That means it only function in one direction when it is put in its proper axis of insertion. So the elevation, the superior rectus will do elevation, intorsion, and adduction. The inferior oblique will do elevation, extorsion, and abduction. So when you put these axes together, you'll find that this one will eliminate this one will eliminate this one. So when you look upward, straight, two muscles will do this upward action, which are the superior rectus and the inferior oblique. And the reverse will be in depression. So when you look up straight, it is the superior oblique and the inferior oblique together. But when you direct your eye in the abducted position and you look upward, then it is only the superior rectus. When you put your eye in the adducted position and you look upward, it is only one muscle, which is the inferior oblique. So when you look upward straight, you have two muscles which elevate the eye, which are superior rectus and inferior oblique. But when you abducted your eye and you look upward, that means like this. So it's only one muscle acting here, which is the inferior oblique, and the reverse. When you look inward and you look upward, the inferior oblique here, this was the superior rectus, and when you look inward and you elevate your eye upward, you have which muscle is acting here? It is the inferior oblique. And the reverse, when you look downward. When you look downward straight, this is the inferior oblique with the superior rectus. When you look in the abducted position, it is the inferior rectus. When you look in the abducted position, it is the superior oblique. So this is to simplify you how the extraocular muscles act together in their all direction of gaze. That means you are looking straight, both eyes have to be straight. When you look this side, so you have the lateral rectus of this eye and the medial rectus of this eye. When I'm looking this side, I have the lateral rectus of this eye and the medial rectus of this eye. When I look straight up, I have both the superior rectus and the inferior oblique. When I look to this side and look up, I have here the superior oblique and here the inferior rectus. And the reverse, when I look to this side up, I have here the inferior oblique and here the superior rectus. When I look down like this, I have the inferior rectus and superior oblique. When I look to this side, I have here the inferior rectus and here the superior oblique. So this is how these muscles act together to direct your gaze, what we call in all direction of, or in all cardinal position of gaze. So you are actually covering your whole field while you are walking in your normal life by the coordination of this extraocular muscle. Whenever you have any disturbance in this coordination, then you will develop a squint. That means your eye will not be straight. You will have what we call crossed eye. So this is simply how the eye acts together. So now, looking to the second part of our topic is that you as a general practitioner or working in an emergency clinic, a pediatrician, a GP, even obstetrician, whatever your specialty is, any mother will ask you, doctor, please look at my child, is he normal or has a crossed eye? So you should guide this family, is your child is normal or not? So in order for us, you have some step to examine a case of squint. Whenever you have a child, you are suspecting is this child is normal or abnormal, he has any abnormality or not. You have to look first straight to his eye and see if his eye is normal or not. That means he's looking straight at you or not. Then start just to move any fixed object in front of him in, as I said before, in his called in the principal direction of gaze: up, down, right, left, left and up, left and down, right and up, right and down. and you see, are these eyes are coordinates, they move together or not. Then if they are not moving together, then you have to think there is some sort of abnormality in this child, then refer him to any ophthalmologist to check. So simple test or simple check you are doing is what we call the corneal light reflex. Whenever I'm looking to a light, that means even the light that is in front of me now, we are going to see there is some sort of reflection in front of my cornea. And this spot of light reflection, this is what we call the light reflex, the corneal light reflex. This reflex has to be the same whenever you are moving your eye, up, right, down, left. So any movement of your eye, you are going to see that this spot of light is in the center. If you look to this side, it will come to this part of the pupil. It has to come also on the same spot on the pupil. So the pupil here will be your guidance, and the cornea, the margin of the cornea will be your guidance, and this light reflex has to be the same whenever the eye is moved. You can see, you can check it even by photo, as is this picture. This is a flash reflection from the surface of the cornea. Can tell you if the light reflex is central or not. Whenever he's looking, the light reflex is the same at any part of the eye. If there is any problem like this picture, we'll find here the light reflex is central on the cornea, and in this one we find that the light reflex should be here, but the light reflex here is at the edge of the pupil. That means this eye is deviated outward. We call this deviation outward exotropia. On the contrary, from the lower picture, you will find that the light reflex here is central, but on the left eye you will find that the light reflex here at the outer edge of the pupil. That means this eye is directed inward. Any inward direction we call it esotropia. Any outward direction we call it exotropia. This is also the same way to show you that the light reflex is not central at the pupil. Here, when the child or the patient is looking straight at you, his light reflex is not central at his cornea. Here it is at the outer edge of the pupil. Here also it is at the outer edge of the pupil. Here the eye is directed inward, which is called esotropia, and the light is directed at not at the outer edge of the pupil, but at the outer edge of the cornea itself, which it means that he has a very evident amount of esotropia, which means that the eye is directed inward. So by simple observation or by simple light reflex, you can tell if these eyes are straight or not. Sometimes the patient gives you a false sensation that he has squint, and this is what we call pseudo squint, because he has a wide interpupillary distance, or he has also what we call epicanthus, or this fold is large, and this is very common in children, and this is a very common presentation for the mother or the family looking at your child and tells the mother, your child has squint, look at him, how he's looking. Why? Because this epicanthus, when the child look to this side, that means to his right side, this eye will move to this side. For the presence of epicanthus, this part will be covered by this fold, contrary to the other side. So the family or the parent will think that this eye is normal and this eye is deviated inward. But if you look at his light reflex, you will find that from the light reflex, the light is central on both cornea. It's a simple test that we do to differentiate if your eye is normal or not. We call it the cover test. We have what we call simple cover test, like this, or alternate cover test, like this. So whenever you have a child who squints, you just do what we call simple cover test. You cover one eye and you remove it, while the child or the patient is looking direct to a toy, a symbol of light or whatever, but don't make sound, so that the child is not directed to the sound, is directed to the light. And you do what we call simple cover test. If there is no movement of the eye, when you do like this, when you do like this, and when you do as an alternate cover test like this, you find no movement of the eye, this is normal child. But if you cover your eye and you remove it, and you cover your eye, you remove it, and you find there is movement occurring under the cover, so there is a problem in this child, you have to refer to ophthalmologist. If you do the same thing like this, and there is movement, then also there should be a problem. And this movement depends, is it inward or outward? Inward is iso, outward is exo. This slide shows you some example of the cover test. Here, there is no shift when you remove the cover. Here, when you remove the cover or you shift the cover from this eye to this eye, the eye will shift. If the eye shift inward, it is iso. If the eye shift outward, it is exo. So by understanding the basic, so we know now that this child has squint, either iso or number one, is it true squint or false squint? And number two, if it is true squint, we have to differentiate which type of squint this child has. We divide squint into pseudo-strabismus. That means that a child or a patient that when you look at him, you think that he has strabism, but when you examine him, he's normal. We call it pseudo-strabism. Or he has true squint. True squint, we divide it into two main, what we call commentant or non-paretic and incomitant or paretic squint. Paretic squint, that there is paralysis of one of the extraocular muscles which can lead to this squint. Non-paretic squint, that means there is no paralysis of any extraocular muscle, so that this squint is related either to refraction or related to other or congenital or related what we call to accommodative type. We'll explain this later on. This is also another example of the same child I showed you, pseudo-strabismus. Back to this slide, we divide the non-paretic squint into what we call heterophoria. Heterophoria, this is the latent squint. Maybe you are going to read this term. Heterophoria is, that means you have a squint, but this squint will not be apparent until you are exhausted. Your refractive error is not fully corrected. We call it latent squint, and this latent squint is sometimes to occur to you, any normal person, in a physiological form. That means when you have any daydreaming, you'll find that you're going to see double vision, and when you try again to concentrate, this double vision will resume or will disappear, and this because your eye will go to, when you are daydreaming, your eye will shift to what we call the position of rest, and then when you concentrate again, the brain will control the eye again, and this will disappear. This is some sort of phoria. And phoria, you can detect it by what we call alternate cover test. Then we'll shift to another form, which is true squint. That means a child will come to you, when you look straight to the eye, you'll find one eye straight and the other eye is shifted, either inward or outward. If it is shifted inward, we call it esotropia. If it is shifted outward, we call it exotropia. For the shifting inward, we have primary, which is either congenital or accommodative. Secondary, that means this squint is not due to one of these causes, but it is caused by a secondary things that happen in his eye which has led to squint. For example, he has done surgery, he received any trauma, he has any disease of his cornea, in his lens, in his retina, so that the vision in this eye has decreased, and this decrease in vision has led to this development of squint. And so, as I said, either it is iso or exo. Exo also, it has the same causes. Then we have what we call vertical problems. That means one eye could be shifted upward, which you would call it hyper, or shifted inward, what we call it hypodeviation. And then we have the third type of squint, what we call it paralytic squint. That means the squint is due to paralysis in any of these muscles, either oculomotor or the abducent or the trochlear nerve. And these are serious problems, because whenever you see a patient or a child with a paralytic squint, that means that the problem is not in his eye, but it is due to nervous problem, either in his brain or any serious condition related to the nervous system itself. So paralytic squint is a serious condition for us. Non-paralytic squint, this is normal condition in us, for us. As we have been taught before, common things are common. If you have squint in a child, this is common. Squint in an old age, this is uncommon, and this should be trigger a red alarm in your brain. Why? Because in this slide you'll see the cause of paralytic squint. Either you have a lesion in the cranial nuclei itself, you have a lesion in the nerve trunk itself, you have trauma to the base of skull, you have a lesion of the muscle itself due to orbital disease, muscle disease, direct trauma to the muscle, and the most important thing, you have a peripheral neuropathy as it occurs in diabetic patient. Paralytic squint is a serious condition because it is related to the nervous system itself. It is related to the brain. It is related to the cranial nerve. So you have to take it very seriously, and you have to do investigation. Even if you are sure that this is a peripheral neuropathy, don't take it as a granted. Routine CT scan or MRI to the brain should be done to any cases of paralytic squint. Each of these nerve will present to you by special presentation. The lateral paralysis, the patient will have problem when he look outward because the lateral rectus itself is paralyzed. So in this slide, when he looks straight, the eye will be straight. But when he look to this direction, if the lateral rectus of this eye is working, it works. And the eye will shift in this direction because both recti work together. But if he's shifting his eye to the other side, this lateral rectus is paralyzed, the eye will not move outward. And this is the picture that we'll have. We'll have a frozen eye on the lateral gaze, and the eye will move freely. Also, you have to check up, down, right, and left. If you look to the third nerve paralysis, if you look, usually when you look to the picture of any squint, you'll find either 9 picture or 6 picture because we have to take the whole direction of gaze. So in this slide, you see from the third nerve palsy, the patient will present to you by paralysis of third nerve. And as we said, all of the muscle of the all the extraocular muscle supplied by third nerve except the trochlear and the superior rectus and the lateral rectus. So the patient will present to you with ptosis, and you'll find that the eye is a little bit direct shifted downward. If you look upwards in this slide, the eye will not move. If you look downward, the eye will not move. If you look to this side, the eye will not move because paralysis of the medial rectus. But if he looks to the outer side, this eye will move because the lateral rectus of this muscle is working because it's supplied by different separate nerve. So this is typical example of a third nerve palsy. There is ptosis, there is slight shift deviated downward, but if you check the extraocular muscle, there is no function of the lateral recti of this muscle, and there is no function for elevation and depression. The superior oblique muscle is characterized by what we called a test, very simple test done to this patient, is that when you move the eye, what we call the head tilt test. The child will usually present you by seeing depression and head tilted toward your right side, but when you try to shift the eye to its proper direction of straight direction, you find that his right eye, where there is a problem, the eye will shoot upward. This is very diagnostic for a superior oblique palsy case. So after you a very important step, examination of any child, if you are a pediatrician, if you are a general practitioner, you have to have an ophthalmoscope. This ophthalmoscope will be your source of light to detect the corneal right reflex and to do a very important step in diagnosis of strabismus, what we call it the red reflex. The red reflex, when you look through the ophthalmoscope, the light will be emitted inside the eye, will come back to you and form what we call the red reflex. It is very common when you take any picture by any camera, you'll find that the eye are usually red, and this is why now the flashes of any new camera, the flash of any new camera, or even the side flash they put in this studio or whatever, the aim of this is that to prevent the production of the red reflex, because the light will come inside the eye, will be reflected, will illuminate the eye, and the retina is usually red in color. This redness of color will be printed in any picture you will have it. So the red reflex is very important for us. Whenever you examine a child, you have to be sure that the red reflex is present, both eyes the same brightness. It's very important. Whenever you find there is loss of any red reflex in any eye, this is a serious condition. You have to refer this child immediately to an ophthalmologist. This is very important for any GP or any pediatrician. And of course, not to mention that what we call retinopathy of prematurity, which is any child in incubator with some criteria, has to be examined by ophthalmology to prevent the complication of retinopathy of prematurity in any premature child. So after that you have sure, or you are now confident this child has a squint, I'm going to give you simple guideline for treatment. You don't have to know how to manage it specifically, but you should know what are the guidelines. What we do to this child? Do we do surgery? We do glasses? Do we do patching or occlusion for some cases? Or do we have to go immediately to surgery? So we have number one, glasses. This is the first line of treatment of any case of squint. Glasses, why? Because you have to correct the vision presented to the eye. So this vision or the picture presented to the eye has to be of the same quality of both eyes. If any picture presented to one eye is not present as the same quality, this child will develop what we call amblyopia or lazy eye. And amblyopia and lazy eye, this is a very serious problem because it is a very simple condition. If it's not treated properly, unfortunately, the child will grow up with a normal anatomical eye, but with defect in vision that you cannot correct in later life. So this is a very important problem to be screened. This is why they do screening program for children in school, in kindergarten, to detect any difference in refraction in both eyes, because amblyopia is caused either strabismus, that means one child got strabismus, and due to this strabismus the brain will focus on the eye that is not squinting, so always the brain will concentrate on this eye and will neglect the picture from the other eye, and then later on when you correct this squint, this eye will not be a proper seeing eye for the presence of amblyopia. Or due to vision deprivation, that means this child had got a cataract, has a corneal problem, has any problem with optic nerve, whatever cause, pathological cause in his eye that led to decreased vision, that led to development of amblyopia. Or refractive and anisometropic, which are the very common causes of amblyopia in a child. Refractive, that means that one eye is normal, the other eye has myopia or hypermetropia. So we'll have a fuzzy picture in one eye and a normal picture of the other eye. The brain will fuse these two pictures together to get a good picture. But if you find that one eye is fuzzy, one is normal, you will neglect this picture and keep it focusing on this eye. So this eye will be always the stronger eye, and this eye will be the weak eye, though it has a normal anatomy. Anisometropia, that means that there are difference between the refraction of both eyes. That, for example, one eye is -1 and the other eye is -6 diopter. Whenever there is more difference, more than 3 diopter, we call it anisometropia. that means the size of the picture will not be the same between both eyes, then he will have a problem in fusion. He will develop amblyopia. Why it is very important? Because if you detect it early in a child, we do the only treatment for the amblyopia is what we call penalization or cover. You have to cover this eye. You have to penalize the brain, to force the brain to look through this amblyopic eye. How? By occlusion. You have to occlude the normal eye and put the glasses. You have to correct the refractive error of the other eye, or if this child has squint, you have to correct the squint and then do the occlusion to force the brain to look through this eye. And we do occlusion this by hours according to the age of sight. We have different types of theory of penalization, either by this simple eye patch or by what we do atropinization. We do atropine in one eye to make the picture blurred. You know, atropine is cycloplegic. That means that it causes paralysis of the extraocular of the ciliary muscle. Then the picture will not be clear. So we reverse the condition. We let the good eye blurred and the normal anatomical eye, we force it to see this eye until the brain get used to see from both eyes. Then we have a schedule for this occlusion, and this is very important. Sometimes if you choose this child in any mall, and why? Because usually we keep them all day for 12 hours and so on. So you might be confronted with any child like this in a mall, in a cinema, in the street. Then you know that this child has amblyopia and he's doing what we call the occlusion therapy for this eye. Glasses is very important for the treatment of what we call accommodative esotropy. Any child who squint, after examination, you have to do what we call refraction. You have to refract the eye of this patient to see if he has a normal refraction or he has either hypertropia or myopia. The most common cause of esotropia is what we call accommodative esotropia. There is difference, or one eye is hypertropic more than 3 diopter, and due to this hypermetropia, if he looks or try to look to anything or try to read anything, due to accommodation, usually we have a convergence. This is normal physiological process. Then by looking inward, the eye will accommodate more, the eye will shift inward. By correcting this refractive error, as this in this child, in this picture, as seen in this slide, the eye, a very obvious left eye has accommodative or has esotropia. He put his glasses, immediately this eye becomes straight. Why? Because you have corrected his refractive error. So the first line of treatment for non-paralytic squint, you do refraction first and then try to correct any refractive error he has. Usually the correction of refractive error will cure his condition. After that, the residual amount you do it by surgery, or if it is not corrected by glasses, you do surgery, but you do surgery after you do any amblyopic therapy for this eye if this eye has amblyopia. And lastly, we revert to surgery. The principle of surgery in our case is very simple, very it is an extraocular procedure. That means the inside of eye is not exposed. The muscles usually are attached outside the globe. So just by cutting through the conjunctiva, and by the conjunctiva it's considered as a skin, by just cutting through the conjunctiva, you get the muscle hooked, and then you do what we call either strengthening procedure or weakening procedure. Strengthening procedure, that means that you move your muscles a little bit in front, so that you strengthen this muscle. Weakness procedure, you move the muscle backward so that you weaken this muscle. The same process of you are trying to catch something hard. If you have a ball and the muscle is here, if you move the muscle in front, you give it more of its tendon, then it will force of its action will be better. If you move the muscle backward, then you are weakening this muscle instead of doing a big force of traction. This is the simple way to do the surgery. And of course we have the obliques, but the oblique muscles are different type of surgery, you don't have to know it. This is the principle of weakening procedure. In the weakening procedure, like in this slide, you identify the muscle, you make a new insertion by means of nylons, special type of suture and filaments. Then you cut through the insertion of the muscle, you make another line of insertion, and you take out all this amount of muscle, its belief with its insertion, and you do a new insertion, but this new insertion is put back away from the original insertion. So you are weakening actually this muscle. In reverse of the strengthening procedure. The strengthening procedure, you are cutting this part of the muscle and you are moving this part here in front of this muscle, so you are strengthening the muscle. To conclude our lecture, strabismus, it's important topic for you to know, especially if you are a pediatrician, a general practitioner, or even if you are a physician. You have to know, differentiate between normal eye position, any abnormal eye position. Any abnormal eye position, we call it squint. This squint could be either non-paralytic or paralytic. The non-paralytic could be inward, iso, outward, exo, hyper, or paralytic squint. Paralytic squint is a serious condition because you have 3 intracranial nerves related immediately inside your brain. Any problem inside your brain, any nervous tissue disease problem, any neoplastic problem, tumor, anything like that, will affect this muscle, and serious condition. You have to do investigation immediately. You have to know when to refer this child or this patient to ophthalmology for proper management. And as I mentioned before, amblyopia is a serious condition in children. If it is not picked up early, if it is not detected early in a child, the child will grow up with a normal anatomical eye, but a non-proper functioning eye. You can restore its vision easily to a normal vision function if you just do occlusion, put glasses, and correct this amblyopia. If all this management fail, you have to go to surgery by the end of the day. Thank you, and appreciate. Assalamu alaikum.